So ribosomal lesions have recently been described in different types of cancers, sort of as these novel, previously unexplored potential factors that influence oncogenesis. And it has not been known what exactly they're doing in a cancer setting. In fact, it's somewhat paradoxical if you study ribosomal lesions that are found in cancer in cell models, for instance, or in vivo in mouse models, it actually causes growth defects, which is paradoxical, of course, because cancer is the opposite of that. And so we've been studying ribosomal lesions in various types of hematopoietic cancers. The summary, basically the main take-home message that I will also present later in my talk, is that these ribosomal lesions are not oncogenic themselves per se, but rather they provide the right environment, sort of the right fertile ground for mutagenesis to occur, and so give rise to genes which are in fact oncogenic themselves. These ribosomal lesions are sort of just providing the opportunity, they open the gates towards oncogenes. So methods are mostly a combination of in vitro cell models, where we can introduce different ribosomal mutations into different cell models, primary cells, genetically engineered isogenic cell models, but also in vivo. We use mice. And then, of course, there's patient data available from exome sequencing studies that we can mine, and so we can look at the number of mutations that patients with ribosomal lesions have, and what type of mutations compared to patients that have wild-type ribosomes, for example. Yeah. So famous oncogenes, there is a few, yes. So first of all, I should say that so ribosomal lesions increase mutagenesis, so it's random mutagenesis, but those mutations that particularly benefit a particular cell will be selected for, of course. And so the one famous for T-cell acute lymphoblastic leukemia is Notch, for instance. It's a mutation that's frequently found in leukemia patients. And we see that patients that have ribosomal protein lesions are significantly enriched for mutations in Notch. Another famous one is P53. So in some cancers and congenital ribosome defective disorders, we also see that P53 inactivations play an important role. In the short term, we can see that a subgroup of patients that have particular ribosomal protein lesions would be more sensitive to inhibition of Notch, for example, in the case of T-cell leukemia, because those ribosome mutant cells are more reliant on particular cellular pathways. So those can be targeted. So I think this work identifies a subgroup of patients that could be treated, that could benefit from particular types of treatment. More long-term, I see that it opens up new avenues for therapeutic intervention attacking the ribosome itself, because ribosomal lesions change the structure and the function of ribosomes enough to perturb the function. And so if you can design drugs that specifically target the structural differences in mutant but not in wild-type ribosomes, you can really specifically target the mutant ribosomes in cancer cells and not in healthy cells. So we're also exploring this, but this is a bit more in its infancy still, but very promising.